Our first speaker today is Prof. Kenneth Boffard from South Africa. He is the father of modern trauma and a vascular surgeon. Professor Ken Boffard is subspecialist in trauma surgery and trauma critical care. He is a trauma director and academic head at Neil Park Hospital Academic Trauma Center and a professor emeritus in surgery of the University of Witwatersrand. He has recently been awarded as a membership of the Academy of Master Surgical Educators of the American College of Surgeons. Professor Boffard is the Secretary General and past President of the International Society of Surgery, ISS, in Switzerland. Past President of the International Association for Trauma Surgery and Intensive Care, I6. He is a colonel at the School for Military Health Training of the South African Military Health Service. His interests include trauma resuscitation, intensive care, military medicine, planning of trauma system, aviation medicine. He is a licensed fixed-wing and helicopter pilot and scuba diving. He is a great trauma surgeon who can fly and dive. It's very amazing indeed to know him. His research interests include coagulation, hemostasis, and education. Prof. Boffard will talk on should a general surgeon train and keep current on vascular injuries. It's a very hot topic. So ladies and gentlemen, let us welcome Prof. Ken Boffard to give his talk. Prof, the stage is yours.
Welcome to everybody, and it's a real pleasure to be back here. My compliments to the organizers and to the sponsors, without whom this sort of thing just wouldn't take place. So we really, on behalf of the speakers, appreciate your invitation. We appreciate and enjoy sharing things with you. I'm a trauma surgeon, and in South Africa, to be a trauma surgeon, you have to be a general surgeon, you have to do some vascular, and you then do intensive care and trauma surgery. So I'm probably talking from essentially the wrong position. Let me start off by saying that we need to establish the scenario. The treatment of vascular injury is to stop the bleeding and restore the circulation. So trauma surgery, there's your patient coming in, and there are the doctors waiting for this particular patient. And each one of them, and maybe the patient too, is saying, what do I do next? And our chairman, Rolando, pointed out that the only way the patient has of retaliating against the incompetent surgeon is to bleed to death. So what do we do next, and who should do it? And if you don't have a plan beforehand, there will only be victims. Neither of these two role players in this particular thing had planned on this particular outcome. I went to the dictionary and looked at what is meant by underexposed, particularly surgeons in peaceful countries. I also went to the dictionary and looked at the definition of overwhelmed. And note, it's reduced to helplessness by too little training or too little patience. What do I do now? That blood is supposed to be in, not out. And who do I treat first? So these are the sort of decisions that a trauma surgeon or a non-trauma surgeon has to make when the patient arrives. Yes, stating the obvious. But things have changed. If you look at surgical training in the United States today, the doctors train for 80 hours a week over at least 6 years of training, and that means that the average trainee has had 25,000 hours of exposure. What happens in Europe is slightly different. They have 40 hours instead of 80 hours. They have reduced training, and their exposure is almost greater than a third of what the Americans see. Now that's a problem because you can only fit just so much in. Solutions. Most Europeans now do general time of 1 year, and the specialty time is increased to 4 years. So if you're a colorectal surgeon, you only have 1 year of general time. If you're a breast surgeon, you only have 1 year of general time. Breast surgeons are not known for their anatomy of the pelvis. Mind you, it's probably mutual. The reality is that most surgeons who take trauma call in most peaceful countries are not trauma surgeons. They have limited general experience, and even those who are vascular trained are very focused and probably have spent most of their time doing internal stuff like R.E.B.O.A at the expense of any general stuff. So in 2021, when the vascular surgeon is faced with a trauma patient, the response is pretty much as you see here. The trouble is, the general surgeon has the same response. The trouble is, there are very few in peaceful countries, and despite the introductory video, most of Southeast Asia is a very peaceful environment with some very hardworking people. So the reality is there are relatively few trauma surgeons. So my first question is, who best knows the anatomy? Yes, the trauma surgeon, because the trauma surgeon has to know where the blood vessels are and has probably been most places. Unfortunately, there are very few trauma surgeons. The general surgeon knows where most of the blood vessels are because he or she studied them in the medical school. But realistically, most general surgeons have an anxiety about blood vessels. And the vascular surgeon knows the anatomy. The vascular surgeon has to, because the vascular surgeon applies himself or herself generally nowadays from the inside of the vessel out. But you know, that's not different to Waze or Google Maps. When you navigate, it doesn't show you where your destination is. It shows you the street that you're on and where you're going to turn left. That's pretty much what a vascular surgeon is doing in many situations nowadays. Just to give you some idea of what we're talking about, in South Africa, we have about a population of 60 million, 1,500 registered surgeons. Very few super specialize in vascular and general, and all work at university or advanced private hospitals. They have to because of the backup facilities. However, here in South Africa, just like in many places in Asia, the emergencies and the trauma do not happen in only the major cities. The vast majority happen on the roads of the slightly more rural areas. So we've got 900 general surgeons and 1,800 senior medical officers in reality, as you have, doing the bulk of your trauma. A little bit of science coming in. Penetrating injury, you can see. Blunt injury, again, Asia, apart from conflicts, is a pretty peaceful country. Not quite as peaceful as Norway, where the city of Oslo, population 1 million, had 5 gunshot homicides last year. Sweden, and I'm sure Tal will elucidate, but Sweden has unfortunately become something of a murder capital of Scandinavia. We're seeing more penetrating injury. In Southeast Asia, the bulk of your problems is car crashes. On top of which, there is a number of injuries which result in thrombosis of the vessels. So what are our diagnostic approach? That's the list, and that's the reality. One of the problems that's happened certainly in Europe is the CT scan has now become therapeutic. Patients are sent to CT scan whether they're safe to do so or not. The CT scan is performed, the patient may get worse, but the resident or the attending doctor is extremely happy. So CTs in many places are therapeutic. They make the doctor feel better, not necessarily the patient. And that's one of the problems that we're dealing with. Insecure doctors tend to want, because that's what they do in their day-to-day practice, rely on tests and diagnostic imaging, particularly in penetrating trauma. A patient with a gunshot leg which is pouring blood doesn't need a CT scan. You know where the injury is. So controlling the bleeding and maintaining blood volume is the key of trauma. We, yes, do use local adjuncts, hemostatic agents, fibrin sealants, particularly on the abdominal organs, Hemcon or Celox dressings in particularly blast injuries and open injuries. The alternative is the chitosan dressing. Quick clot, which is exothermic. It's always a little off-putting to see smoke coming out of a wound. It's very exothermic. The new ones come in tea bags. It's not quite as exothermic and not quite as effective. 400 years ago, the Brits treating amputations by dipping the limb in a hot tar. I think quick clot may be the 20th century, 21st century variation of that. So there's all of these things that are used as a local hemostatic agent. Never forget the Foley catheter. Here's a stab wound of a patient's upper part of the neck, and putting in Foley catheters can block the bleeding. The trouble is, sometimes they just stop the blood coming out. And pretty much contemporary now are tourniquets. A warning, tourniquets generally, and as shown in this picture, there's always a white tag or somewhere where you can write, if you're going to put a tourniquet on, write the time the tourniquet was on. This patient, who should not have had a tourniquet for what is essentially a lower limb injury and should have had a blood pressure cuff put on that, blown up if it was bleeding, this patient went through 3 referral hospitals over 6 hours and lost his leg from a preventable injury because nobody knew when the tourniquet was put on. What's new? Well, R.E.B.O.A, resuscitative endovascular balloon occlusion of the aorta. Pathophysiology will give you, and he is probably one of the masters of R.E.B.O.A, and the idea is that it is put in through the groin. It can be put in pre or in hospital and inflated, and it will actually close off the vessel. Can be done pre-hospital, can be done in emergency areas, and it can be done in the operating room. I think the jury is still out. When you have a new hammer, everything looks like a nail. And there are a couple of problems with R.E.B.O.A. One is it is extremely expensive. 2, it is not without risk. And 3, it is not without time in inexperienced hands to be inserted. So it's got to be done by people who are familiar with it and comfortable with doing it quickly. The trouble is, those are in the better centers, and it doesn't actually help in the smaller areas. And Pathophysiology runs a spectacular training course to try and improve that. The bottom line is there are 13, or used to be, but there have always really been 14 clotting factors. And I would submit to this meeting that the management of trauma is factor 14. And factor 14 is the surgeon. Pressing on the blood vessel stops more bleeding than all of those other adjuncts put together. You can use regional adjuncts. You can use systemic adjuncts. Coagulopathy is a big problem. So what does this bring us down to? Well, let's look at the 3 that we spoke about. The trauma surgeon knows the anatomy, including the neck. Many other surgeons are very frightened of the neck because there's things that bleed in there. The trauma surgeon can absolutely access the chest, is definitely used to uncontrolled surgery because that is what trauma is. Trauma respects no anatomical boundaries. And the trauma surgeon is definitely used to uncontrolled bleeding. The trauma surgeon's first weapon is factor 14. The trauma surgeon's a little anxious where he's talking about arch of the aorta and brachiocephalics and so on, and cardiothoracic territory. But you know, I found cardiothoracic surgeons live in the nicest areas, often some distance from the hospital. And in the middle of a bypass, it's sort of difficult for them to help. But the last thing also is that trauma surgeons know the physiology of the patient. You have to try and make the patient fit for surgery as well as the surgery appropriate for the patient. So that brings me to the vascular surgeon. R.E.B.O.A will have the right of reply. The vascular surgeon does know the anatomy, even the neck, or at least the overview of the anatomy. And I would submit that in the absence of trauma surgeons, vascular surgeons may at least know their anatomy, even in the chest. The trouble is, they're not used to uncontrolled surgery. Many vascular surgeons are obsessive compulsive because they have to be, and any flexibility is not immediately visible. And they're certainly not used to uncontrolled bleeding. That's the last thing that they want. But they do have good experience with blood vessel repair, but not quite so good at proximal control immediately, particularly R.E.B.O.A and clamping, and not quite as good on the physiology, because like the general surgeon, they rely on the anesthetist. The general surgeon knows the anatomy, that's why they're called general, can access the chest, may have to deal with trauma, may be used to uncontrolled bleeding, but not very good at blood vessel repair, because that's the domain of the vascular surgeon. And with most planned vascular surgery, that's the referral pattern. So who is going to be better of the three, excluding the trauma surgeon, because there just aren't enough? Well, one of the things we've got to avoid is inappropriate surgery. Not only do we learn from our mistakes, but we have to learn not to apply our own training and mores to something which is not appropriate fit. So in trauma surgery, you do have to think outside of the box. It's more difficult for the vascular surgeon and more difficult for the general surgeon. Know the political environment in which you work. Many people work in a hierarchy. To be honest, I don't want the professor of pancreatic surgery exploring my neck. You have to do more with less, because that is the nature of trauma. Know the demographics of your trauma. What are you going to expect? What do you have to have in place? If you are particularly expecting major abdominal penetrating vascular trauma, you should be potentially versed in things like R.E.B.O.A. Unfortunately, we've seen at least one death from R.E.B.O.A with a stab wound of the aorta, where the R.E.B.O.A balloon was actually unfortunately put into the R.E.B.O.A, into the aorta and out through the stab wound. Everything needs to be documented. Please exhibit curiosity when other people improvise, and never condemn what had to be chosen in short time at the time. And learn from the competition. Learn from what vascular surgeons do. Learn from what pancreatic surgeons do. Don't condemn it because you hadn't thought about it. Excellence is not a monopoly. You need to compete to achieve excellence. Perfection is the enemy of good. Stopping the bleeding is better than an absolutely meticulous repair with a dead patient. Choose the surgery. Only do the surgery that the physiology allows. And if you can, choose the surgeon, which probably means, particularly in an urban environment, choose your hospital, because it's a team. Learn, if you are going to deal with trauma, to the two major training courses which will enhance what you do. The trouble with the pancreatic surgeons is that they don't know the neck. The trouble with a vascular surgeon is they don't know the pancreas. The American College of Surgeons, and I believe it is in Singapore and elsewhere, is the ACID course. It doesn't matter who does the surgery, provided they're properly trained, sufficiently experienced, and humble enough so that when they run out of ideas, they know who to ask. The ACID course, and you will be able to get the videos, I would suggest you access it and have a look. The way it works, and it works in partnership with the DSTC course, which I shall mention, but the ACID course gives you real life patient scenarios and then says, you know what, in order to deal with that, you have to know where this injured area, and this is the way, and they use cadavers, they use some simulation, this is the way you approach it. Most of you are familiar. Singapore was one of the early leaders of DSTC. Philippines has got DSTC. Thailand has got DSTC. Australasia has got DSTC. It is in 33 countries in 7 languages. It is the world's most advanced open surgical course. It involves anesthesia, general surgery, and nurses. Many of you have heard me say, when my scrub nurse turns around and said, Prof, have you thought of using this particular instrument? It may make your life easier. What she's actually saying is, what's going on? You should have used that a long time ago. So the definitive surgical trauma care works in the same way. Brief lectures, discussion on patients with competing priorities. Do you deal with the abdominal bleeding or the chest bleeding first? Do you deal with a bleeding spleen or the bleeding liver first? Because you can't deal with two of them simultaneously. It uses patient scenarios and teaches all the skills needed for a non-trauma surgeon to save life. There is a prayer known to pilots. It says, "O Lord, whose mercy we revere, we should know we should not be up here." And I would say that most surgeons dealing with trauma are a little anxious about being in there. And it helps if you have a routine and a protocol. That's what the rest of the seminar is about. I'd like to thank the organizers. I'd like to thank Aesculapius and Academy and Brown. And I hope you all have a great seminar. Thank you very much.